MRI or some kind of cross-sectional imaging, and even then, abnormalities in flow may look like a thrombus and they're not a thrombus. So it's indispensable to look at the images with the radiologist, all right? If you confirm that in fact there's a portal vein thrombosis, you start immediately anticoagulation. So you have to closely monitor with lactates and with symptoms to see if there's mesenteric infarction. And if there is, you have to discuss with the surgeon whether there's intestinal resection that will be required. Thrombolysis is not recommended because there's a high mortality and complications. You just have to start anticoagulation, ideally with heparin at the beginning. And if the patient has an underlying prothrombotic disorder, recurrent or intestinal ischemia, or family history of thrombosis, then you have to consider long-term anticoagulation in these patients forever, all right? Now, this is totally different. The acute thrombosis is a medical emergency, particularly when it's extending into the SMV. Chronic portal vein thrombosis, you have a little bit more of time. And how do you know that it's chronic? It's chronic because it's given you time to make collateral. So there's a clot, the black thing is a clot, all the little vessels are little collaterals are trying to bridge between the portal vein on one side of the thrombus and the portal vein on the other side of the thrombus. So you have a mass of vessels that are little collaterals, that is called the cavernoma. And the presence of a cavernoma in a patient without cirrhosis indicates that this is a chronic portal vein thrombosis. So what are the complications? Like I showed you at the beginning, the closer you are to the varices, like in portal vein thrombosis, the more likely you are to form varices and to bleed from the varices. So gastroesophageal varices may develop early, much earlier than in cirrhosis, for example. And it's more frequent to have ectopic varices, like in the duodenum, anorectal region, and gallbladder, is more frequent than in cirrhosis. Portal hypertension gastropathy, you almost never see that because I think there's an element of liver dysfunction that is there. Ascites and encephalopathy are very, very rare. Remember, because this is pre-hepatic. The sinusoids are not affected in the minimum. And there's a new entity there's an entity that's called portal cholangiopathy, which is extra or intrahepatic bowel duct obstruction due to the compression by the cavernoma. And this may lead to abnormal liver test, cholestatic pattern, or symptoms like cholangitis or pain, etc., in up to a third of the patients. So, I thought I had, this is it. So this is the biliary cholangiopathy. Well, I'll go back. So what do you think from chronic portal vein thrombosis? You consider long-term anticoagulation in patients with underlying prothrombotic disorder. Again, if they have recurrent thrombotic episodes, if they have thrombus in another part of the body, like deep venous thrombosis, if there was intestinal ischemia or a family history of thrombosis, these patients require anticoagulation forever. The management, this is in a way, talking about the management of varices and variceal hemorrhage is exactly the same as in cirrhosis. You screen for varices, you prevent the first hemorrhage with beta blockers or ligation in patients who have not bled. In patients who have bled, then you have to do ligation and beta blockers. So it's exactly the same guidelines for the patient with cirrhosis applied to the patient with chronic portal vein thrombosis who have varices or bleed from varices. In patients with recurrent variceal hemorrhage or who develop chronic abdominal pain, perhaps because of this congestion, you should evaluate the possibility of putting a TIPS. But the problem is, it depends on whether there is anything patent besides the thrombus. We recently had a case in the hospital where the patient came in with a chronic portal vein thrombosis, where he has varices but never bled from them, but he has chronic abdominal pain, and the problem is that he has thrombosed everything. The whole portal vein, the intrahepatic branches, all the way to the splenic vein, all the way into the SMV, and there's no way to put a TIPS in there. So you have to, again, discuss with your interventional radiologist whether there's any possibility of putting a TIPS in there to increase the patency of the portal vein. And you can do a MRCP, a cholangiopancreatography, to assess the presence and grade of portal cholangiopathy. So this is what I'm showing you here. This is biliary cholangiopathy or biliopathy. And then in the left graph, this is the portal collaterals that cover norma that's encasing the common bile duct. And on the right side, you can see this is the same patient with that obstruction. You can see bile duct dilatation. Now, this patient may or may not be symptomatic. They may have just a cholestatic pattern, but they may also have liver pain, biliary pain, and also may have cholangitis. So, management of portal cholangiopathy is also deoxycholic acid if the liver tests are abnormal with a cholestatic pattern, or if there's symptomatic portal cholangiopathy. ERCP, if symptomatic biliary structures, or if there are stones in the choleticus. The tips in select severe cases with recurrent cholangitis may be indication. And biliary intestinal bypass should not be done in these patients, even though it sounds like attractive, because these people are going to have high rates of morbidity and mortality. So I have talked about the first one, the extrahepatic, prehepatic, but the others depend on what the etiology is. If it's schistosomiasis, you have to treat the bug, right? If it's NRH, you have to figure out what is leading to NRH. If it's post-sinusoidal and it's SOS, you have to figure out if there's a chemotherapeutic agent that is causing this and work on that. And if it's post-hepatic, like the Budd-Chiari syndrome, there's a whole set of guidelines to treat these patients. So for all the causes of non-cirrhotic portal hypertension, specific management is per guidelines. Now, management of varices, variceal hemorrhage, or ascites in these is exactly the same as for patients with cirrhotic ascites or with cirrhosis and varices and variceal hemorrhage. Thank you very much for your attention.